Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Glad to be here for this one.
Yeah, you know that feeling at 2 a.m.? A blunt trauma rolls in, hypotensive, tachycardic, totally unresponsive.
We've all been there.
Right. You got a massive pelvic binder in place, the airway is being secured, and your first line of sight into the abdomen and chest is the FAST exam.
Exactly. It's your eyes on the inside.
But here's the reality, right? Staring at that screen and calling a false positive because you mistook a side lobe artifact for a bladder clot, or, calling a false negative because you just didn't sweep the caudal tip of the liver, that can literally be the difference between a life save and a catastrophic morbidity.
Yeah, the stakes are incredibly high.
So today we are embarking on a comprehensive clinical masterclass on the FAST and eFAST protocols.
A true deep dive.
Absolutely. The mission of this deep dive is to arm you, the U.S.-trained trauma or surgical critical care surgeon, with advanced evidence-based insights to refine your resuscitative decision-making when absolutely every second counts in the trauma bay.
And for this, we are drawing directly from the definitive clinical guide, specifically the Clinical Guide to FAST and eFAST Ultrasound in Trauma by Cristancho, Rubiano, and Rodriguez.
It's a fantastic text.
It really is. And we are bypassing the elementary basics today. We're going to extract the historical context, the foundational physical principles that dictate tissue echogenicity, and the precise execution techniques for complex anatomy.
Plus the statistical diagnostic performances of recent meta-analyses, and crucially, the physiological pitfalls that mimic true pathology.
Right, because the way we use this machine today is entirely dictated by how it entered the trauma bay in the first place. We have to trace those origins.
It's wild to think about. It's an indispensable piece of medical technology that genuinely has its roots in submarine warfare.
I mean, literally tracking U-boats.
Yeah. The first piezoelectric generator was deployed back in 1917. But the vast potential of bouncing sound waves off unseen targets wasn't fully realized until World War II with the development of sonar systems.
It's amazing, really. We took a technology designed to find submarines in the Atlantic and turned it into a tool to find hemoperitoneum in the retrovesical space.
But the translation from oceanic sonar to human tissue took decades of refinement, right?
Absolutely. I mean, in 1959, we saw the introduction of the Doppler effect to detect peripheral arterial flow. But the real turning point for diagnostics was the introduction of grayscale imaging in 1971.
Because before that, clinicians were essentially looking at blips on an oscilloscope.
Right, exactly. Grayscale imaging allowed for the differentiation of acoustic impedance between tissue densities. It transformed a one-dimensional signal into a two-dimensional anatomical map.
But the real trauma bay revolution didn't hit until the 1990s.
Yeah, that's when things really took off.
Some colleagues published a landmark prospective study in 1992 that really set the stage. They took 163 blunt trauma patients and had trauma fellows, not radiologists but surgeons in their 6th postgraduate year, perform ultrasounds within the first hour of arrival.
And their training was minimal, relatively speaking.
Right. They had just 1 hour of theoretical training and 1 hour of practical training. And the results were a 91% sensitivity for detecting hemoperitoneum.
Let's contextualize the statistical profile from that early 1992 data, though, because it set a dangerous precedent that we still battle today.
How so?
Well, for the detection of specific intra-abdominal lesions, some reported a sensitivity of 69% and a specificity of 99%. But likelihood ratios are what actually dictate our clinical moves.
Right, the LR plus and LR minus.
Exactly. They found a positive likelihood ratio, or LR plus, of 69, and a negative likelihood ratio, LR minus, of 0.31. And then Rozicki's group followed up in 1993 with a larger study of 476 patients.
Evaluating both surgeons and fellows.
Right, yeah. And they found an LR plus of 17.96 and an LR minus of 0.22.
Okay, let's unpack this. Because a positive likelihood ratio over 10 practically guarantees that what you're seeing is real.
Right. If the FAST is positive, there is a massive probability that there is blood in that cavity.
But an LR minus sitting between 0.22 and 0.31 is a profound clinical trap.
It is the ultimate trap of false reassurance. I mean, an LR minus of 0.22 is nowhere near low enough to guarantee the absence of injury.
So if you have a patient with a high pretest probability of a bleed, like a high-speed motor vehicle collision with a seatbelt sign across the abdomen, a negative FAST does not rule out an intra-abdominal injury.
Not at all. You absolutely cannot confidently admit that patient to an unmonitored floor based solely on a negative scan.
But wait, If the negative likelihood ratio isn't low enough to definitively rule out a bleed, it begs the question of why the American College of Surgeons confidently baked it into the ATLS algorithm so early on.
That's a great question.
I mean, they integrated it into the curriculum by 1997. It seems contradictory to rely on a test with such a known blind spot. It's like using a flip phone today and expecting smartphone results.
Well, the ACS recognized that the power of the FAST exam lay in rapid triage, not comprehensive anatomical exclusion. It was adopted as a tool for rapid, life-saving inclusion.
Ah, okay. That makes sense.
Right. In a hypotensive, unstable trauma patient, you need to know immediately if the abdomen is the source of the hemorrhagic shock. If the FAST is positive, you bypass the CT scanner and head straight to the operating room for an exploratory laparotomy.
It shaved critical minutes off the time to intervention.
Exactly. And that evolution in operative thinking is mirrored in the name itself. In 1996, it was known as Focused Abdominal Sonography for Trauma.
But by 1999, the Scalia Consensus Conference changed the A from abdominal to assessment.
Yeah, and that semantic shift acknowledged a holistic approach to damage control resuscitation. It wasn't just about the belly anymore. It was about interrogating the entire torso for reversible causes of shock.
Which leads perfectly into understanding the physical limitations of the sound waves themselves. Because extending the exam to the pericardium and the thorax requires a surgeon to fundamentally understand the physics of the probe.
You absolutely cannot interpret complex thoracic artifacts if you do not understand how the machine constructs the image based on acoustic impedance.
So let's break down the physics of the probe. Mastering the machine. Medical ultrasound utilizes frequencies ranging from 1 to 60 megahertz, right?
Yes, and the foundational constant programmed into every machine is that longitudinal sound waves travel at a constant speed of 1,540 meters per second through human soft tissue.
1,540 meters per second. That constant is the assumption the machine's computer makes to calculate depth.
Exactly. The transducer emits a pulse, waits for the echo, and calculates the distance based on that assumed speed. And this entire process relies on the piezoelectric effect.
Which happens inside the footprint of the transducer.
Right. Inside are crystals, typically lead zirconate titanate. When an electrical current is applied, these crystals mechanically deform and vibrate, emitting sound waves during the emitting phase.
And it's a continuous cycle, isn't it? A cycle of emission, a brief phase of balance, and then the receiving phase.
That's it. When the echoes bounce back from the internal organs, those same crystals vibrate again, converting that mechanical energy back into electrical impulses.
And then the machine translates the amplitude of that returning signal into a shade of gray on the screen.
Precisely. And the amplitude of the returning echo is entirely dependent on the acoustic impedance mismatch between two adjacent tissues.
Okay, so when sound waves hit a dense structure with high impedance, like bone or a gallstone, almost all the sound is reflected back.
Yes, which creates a strong echo displayed as bright white or hyperechoic.
Whereas a fluid, conversely, has very low impedance, so it transmits sound waves easily without reflecting much back.
And the machine displays that fluid as black or anechoic. Soft tissues display various shades of gray, ranging from hypoechoic to isoechoic patterns, just depending on their density.
So the physical properties of the transducer you select really dictate your diagnostic capabilities. Linear probes use higher frequencies, typically 6 to 13 megahertz.
Emitting waves in a straight parallel configuration, yeah.
While convex or curved probes use lower frequencies, usually 2 to 5 megahertz, and emit waves in a fan-shaped pattern.
And this represents the inescapable physics trade-off between resolution and penetration.
It's like a floodlight versus a laser pointer.
That's a perfect analogy. Higher frequencies, your laser pointer, provide exquisite axial and lateral resolution. You can differentiate structures separated by mere millimeters.
But they lack depth.
Right. High-frequency sound waves attenuate rapidly as they travel through tissue. Their functional penetration depth is really only about 6 centimeters.
So great for up-close detail like the pleura, but terrible for deep structurals.
Exactly. Lower frequencies, your floodlight, have longer wavelengths. They can penetrate deep into the body, up to 30 centimeters, but you sacrifice that crisp spatial resolution.
Which is why we use a 3.5 megahertz convex probe for the abdominal FAST. It's the optimal compromise.
You need the penetration depth to evaluate the hepatorenal recess in a 250-pound adult, while still retaining enough resolution to distinguish the anechoic stripe of a fresh hemorrhage from the surrounding hypoechoic paranephric fat.
But selecting the correct probe is only the baseline. A surgeon has to manipulate the knobology dynamically.
Oh, knobology is huge. You have acoustic power adjusting the voltage to the crystals, depth controls to center your target, and focus to converge the waves at specific tissue planes.
And then there's gain, which is notoriously misunderstood.
Very much so.
I see residents crank the master gain all the time when an image is dark. But gain isn't altering the power of the sound waves going into the patient. It's just adjusting the amplification of the electrical signal returning to the machine.
Right. If you crank the overall gain, the entire screen just washes out in white noise, completely obscuring subtle anechoic fluid collections.
That is where time gain compensation, or TGC, becomes essential.
Sound waves lose energy as they travel deeper into the body due to attenuation. So the echoes returning from a deep structure, like the posterior aspect of the liver, will naturally be weaker than echoes returning from the anterior abdominal wall.
So if you rely solely on overall gain, the superficial tissues will be blindingly white while the deep tissues remain completely dark.
Exactly.
I like to think of TGC like audio mixing for a live band. If the bass guitar representing the deep structures is too quiet compared to the vocals, which are the superficial structures, you don't turn up the master volume on the entire soundboard.
Because if you do, you blow out the vocal.
Exactly. Instead, you specifically slide up the EQ fader for the bass. TGC allows you to selectively amplify the weak echoes returning from deep sectors to create a uniform, homogeneous image from the skin line to the retroperitoneum.
And if you fail to adjust your TGC, you can completely miss a massive retroperitoneal hematoma because the lower half of your screen is artificially black.
But even with flawless knobology and perfect TGC, the physics of sound wave propagation inherently creates artifacts, right?
Always. Shadows and enhancements that do not represent true anatomy. And these artifacts are frequently misinterpreted as pathology by inexperienced operators.
So we have to decode those shadows, because once you shine that floodlight into the body, it doesn't always reflect back a perfect image.
But what's fascinating here is that artifacts aren't just annoyances, they are diagnostic clues.
Okay, let's go through them. We have reverberation artifacts, creating horizontal bands when sound bounces back and forth between two highly reflective surfaces, like the pleural line.
We also have mirror imaging, where a structure like the liver is duplicated above the diaphragm, and then the big ones, acoustic enhancement versus acoustic shadowing.
Break down acoustic enhancement for us.
It is a prime example of an artifact acting as a confirmation of pathology. When sound waves travel through a fluid-filled structure like a pocket of hemoperitoneum, they are not attenuated to the same degree as they would be by solid tissue.
So the sound waves that strike the tissue directly behind the fluid are unusually strong.
Right. The machine registers these abnormally strong echoes and paints the deep tissue artificially bright.
So if I see an anechoic space and the tissue directly beneath it is glowing bright white, that acoustic enhancement confirms the black space is indeed liquid.
Exactly. It differentiates a true fluid collection from a really dark, hypoechoic solid mass, like a hematoma that has begun to organize and clot.
Conversely, an acoustic shadow occurs when sound hits a highly dense specular reflector, like a rib or a calcified gallstone.
Right. The object reflects or absorbs the entirety of the sound beam, leaving no energy to penetrate deeper. So the machine receives zero echoes from the tissue behind the dense object, painting a pure black shadow stretching downward.
You also have edge shadowing caused by refraction at the curved edges of fluid-filled structures, like the borders of the gallbladder or the bladder.
And we can't forget beam width, slice thickness, side lobe, and double image artifacts. Double image is like a lens effect from the rectus abdominis.
But the spatial artifacts are what really burn people. I see residents get burned by side lobe artifacts constantly. Oh, all the time.
They're scanning the bladder, looking for a pelvic bleed, and they see a bright hyperchoic structure floating in the anechoic urine. They panic, assuming it's a massive bladder clot or active extravasation. If I'm looking at that, how do I know if it's real or just a side lobe artifact?
It comes down to understanding the geometry of the beam. The side lobe artifact is a function of the transducer's beam profile. The probe emits a main central lobe of sound, but it also emits weaker side lobes projecting off at angles.
Okay.
If a side lobe strikes a strong reflector outside your intended field of view, like a loop of gas-filled bowel adjacent to the bladder, that echo bounces back to the transducer.
And the machine gets confused.
Right. The machine's processor falsely assumes every returning echo originated from the main central beam. It therefore misplaces that off-axis echo, projecting a bright dot right into the middle of your anechoic bladder.
So how do you fix it?
To prove it's a side lobe artifact and not a true clot, You change your angle of insonation. You fan the probe or slide it to view the bladder from a completely different anatomical plane. Because a side lobe artifact is a geometric projection error, so it will dramatically change position or disappear entirely as you alter the angle.
Exactly. A true three-dimensional blood clot will persist in the center of the bladder regardless of your scanning plane. It demands dynamic interrogation of the tissue. You absolutely cannot interpret a static image.
Which brings us perfectly to executing the abdominal fast. Because now that we know how to optimize the machine and read the shadows, let's actually put the probe on the patient.
Navigating the classic 4Ps, perihepatic, pericardial, perisplenic, and pelvic windows.
Let's start with the perihepatic window, specifically Morrison's pouch. You place the probe in the right mid-axillary line, around the 7th to 8th rib, visualizing the interface between the liver and the right kidney.
Statistically, this is the highest yield location to identify hemoperitoneum in blunt abdominal trauma. But simply identifying the hepatorenal interface is insufficient.
Right, because Morrison's pouch is a dependent recess. Blood pools there, but you have to sweep.
You must fan through the entire interface, from anterior to posterior, through at least 2 full respiratory cycles. The diaphragm pushes the liver and kidney in and out of your beam path. If you hold the probe stationary, the pathology might literally slide past your field of view unobserved.
The critical failure point I observe is operators not sweeping down to assess the caudal tip of the liver.
That is such a common pitfall.
The caudal tip is effectively the superior boundary of the right pericolic gutter. When an organ bleeds, the blood doesn't instantly teleport into the deepest part of Morrison's pouch. Small volumes, maybe 100 or 200 cc's, will frequently pool at the caudal edge of the liver first,
Creating a tiny, sharp anechoic triangle.
Exactly. If your sweep stops at the mid-kidney and you don't trace the liver all the way down to its tip, you will miss an early, active arterial hemorrhage.
Next is the pericardial window. The standard approach is subcephoid, utilizing the left lobe of the liver as an acoustic window, angling the beam cephalid toward the left shoulder.
And you must ensure your depth setting is deep enough to visualize the posterior space, because fluid accumulates dependently. A small pericardial effusion will pool posterior to the left ventricle before it wraps circumferentially around the right ventricle.
But in a crashing trauma patient, the sublephoid view can be practically impossible to obtain.
Oh, for sure. The patient might be morbidly obese, or they might have massive subcutaneous emphysema, or they are awake and demonstrating severe voluntary guarding due to abdominal pain.
You cannot force a subcephoid view if the anatomy fights you. You have to seamlessly pivot to an alternative.
Like a peristernal long axis or short axis view. Leaving the trauma bay without definitively clearing the pericardium is a critical error.
The third window is the perisplenic view. Left posterior axillary line, 7th to 8th intercostal space. This is universally considered the most technically demanding view.
Because the spleen provides a drastically smaller acoustic window than the massive right lobe of the liver, the ergonomics are just completely different.
You usually have to drop your hand, placing your knuckles practically flat on the stretcher, reaching far posterior and aiming anterior encephalad.
And the fluid dynamics in the left upper quadrant are entirely distinct from the right. On the right, blood flows relatively unimpeded down the right pericolic gutter into Morrison's pouch.
But on the left, the phrenicolic ligament acts as an anatomical dam.
Right. It tethers the splenic flexure of the colon to the diaphragm, effectively blocking the flow of free fluid down the left pericolic gutter.
Because of the phrenicolic ligament, blood originating from a splenic laceration tends to accumulate superiorly and subdiaphragmatically.
So you must deliberately interrogate the subphrenic space between the superior pole of the spleen and the diaphragm.
You then trace the splenorenal recess and finally evaluate the inferior pole of the left kidney, where fluid will eventually spill over the ligamentous dam.
The final component of the abdominal assessment is the pelvic window, utilizing a suprapubic approach.
In females, you are interrogating the pouch of Douglas, or the rectuterine pouch. In males, the retrovesical space.
You have to hunt for the classic double wall sign in men, where anechoic hemoperitoneum outlines the outer muscular wall of the bladder, while the anechoic urine outlines the inner mucosal wall.
And here is the absolute golden rule of trauma resuscitation. Perform the pelvic fast before anyone inserts a Foley catheter.
Yes, a decompressed bladder obliviates your acoustic window. Once the urine is drained, you are left attempting to transmit high-frequency sound waves through air-filled loops of small bowel.
and air completely scatters the ultrasound beam, rendering the pelvic view uninterpretable.
Let's discuss the absolute volumes required to actually detect hemoperitoneum. A classic study by Branny et al. Demonstrated that the mean minimum detectable fluid volume in Morrison's pouch was 619 milliliters.
Though highly experienced operators could identify volumes as low as 400 milliliters.
But Abrams and colleagues showed that physiological positioning drastically alters sensitivity. By placing the patient in a mere 5-degree Trendelenburg position, operators detected volumes as low as 250 milliliters.
Placing the patient in Trendelenburg leverages gravity. It recruits small pools of blood from the deep pelvis and the pericardial gutters, draining it cranially into the perihepatic and parasplenic recesses where your probe is stationed.
It artificially concentrates the hemoperitoneum, significantly lowering the threshold for sonographic detection.
We've tried to quantify these fluid volumes with scoring systems too, like the Huang score.
Right. It assigns 1 point for each anatomically positive area, an extra point for visualizing floating loops of intestine, and 2 points if the fluid depth exceeds 2 millimeters in either the right or left upper quadrants.
Statistically, a Huang score of 3 or higher correlates to a 96% probability of requiring a therapeutic laparotomy.
Alternatively, you have the McKenney score, which factors in the depth of the deepest fluid pocket measured in centimeters.
While intellectually rigorous, I will say these scoring systems are rarely calculated formally during a chaotic damage control resuscitation.
Because the immediate clinical question is binary. Is there an indication for emergent laparotomy?
Exactly. However, understanding the criteria behind the Huang score trains your eye to estimate volume rapidly. Recognizing that a subtle 2-millimeter anechoic stripe requires different management than massive, free-floating loops of bowel suspended in blood is a critical skill.
This raises a practical execution question, though. Here's where it gets really interesting. Does the sequence matter? Do I reflexively start in the right upper quadrant because Morrison's pouch is statistically the most common location for fluid? Or do I go straight for the heart?
The execution sequence must be entirely dictated by the patient's clinical context and hemodynamic status.
Unstable versus stable.
Right. In a patient arriving with profound refractory shock, you place the probe directly on the pericardium. You must instantaneously rule out an obstructive cause of shock, such as cardiac tamponade, which demands immediate needle decompression, or a resuscitative thoracotomy.
You address the most rapidly lethal physiology first.
Exactly. Conversely, for a stable patient, or a less experienced operator learning the exam, starting at the pelvis is highly recommended.
I agree with that approach. Visualizing the full bladder provides a perfect internal acoustic window baseline. It allows the operator's eye to adjust to what a true, pure anechoic fluid collection looks like on that specific machine's monitor.
Under the specific ambient lighting of the trauma bay.
Yeah, you lock that sonographic signature into your brain, and then you hunt for that exact shade of black in the upper quadrants.
But historically, the FAST exam used to stop at the diaphragm. As trauma care evolved, we realized we were ignoring half the torso.
Enter the E in eFAST, the extended FAST.
Introduced formally into the lexicon around 2004 by Kirkpatrick and his team.
They demonstrated that ultrasound is exquisitely sensitive to the interface between the visceral and parietal pleura. It provided a rapid, radiation-free modality for detecting both pneumothorax and hemothorax.
And the statistical validity of thoracic ultrasound is undeniable.
Let's look at the Staub 2018 meta-analysis. They evaluated an initial pool of nearly 11,000 publications, isolating 19 high-quality studies.
For the diagnosis of pneumothorax, they calculated a sensitivity of 81%, a specificity of 98%, an LR plus of 67.9, and an LR minus of 0.18.
The area under the curve was 0.979. A specificity of 98% and a positive likelihood ratio approaching 68 dictates our management algorithms.
False positives for pneumothorax on ultrasound are exceedingly rare.
If you are assessing an unstable trauma patient and you identify definitive sonographic signs of a pneumothorax, you can confidently drop a chest tube. You do not wait for a portable chest x-ray.
However, for identifying a hemothorax, the sensitivity in that same meta-analysis drops significantly to 60%.
Even while the specificity remains at 98%, why does the sensitivity drop so much?
The drop in sensitivity for hemothorax is a function of patient positioning and blood rheology. Blood within the pleural space rapidly coagulates, changing its sonographic appearance from anechoic to echogenic, mimicking consolidated lung tissue.
Furthermore, in a supine trauma patient, blood layers out dependently in the posterior costophrenic recesses.
Right. An anterior or mid-axillary ultrasound probe will not detect a posteriorly layered hemothorax until the volume is massive enough to track anteriorly. A negative thoracic ultrasound does not definitively mean the chest is dry.
Let's discuss the mechanics of the thoracic scan. The patient is supine. You place the probe in the mid-axillary line, typically around the third to fourth intercostal spaces.
But we transition away from the low-frequency convex probe.
We require a high-frequency probe like a 7.5 to 10 megahertz linear array because the pleura is a superficial structure.
You are interrogating the tissue for two normal physiological markers. First, the presence of pleural sliding. In a healthy hemothorax, the visceral pleura and parietal pleura are intimately opposed.
Separated only by a microscopic layer of lubricating fluid.
As the patient respires, the visceral pleura physically glides against the stationary parietal pleura. Under high-frequency ultrasound, this mechanical friction creates a shimmering, hyperechoic line, often described as marching ants.
Second, you look for A-lines, which are horizontal, equidistant reverberation artifacts mirroring the pleural line deep into the lung field.
You will also occasionally encounter B-lines. These are vertical, laser-like hyperechoic lines that originate at the pleural interface and shoot vertically down to the bottom of the screen,
completely erasing the horizontal A-lines as they pass through them.
Exactly. A few scattered B-lines per lung field are normal, but they represent a critical diagnostic confirmation. The visceral and parietal pleura absolutely must be in physical contact to generate a B-line.
Therefore, if you visualize a single B-line, you have definitively ruled out a pneumothorax at that exact intercostal space.
That concept is rooted in the physics of the disease. A pneumothorax is defined by air entering the pleural space, physically separating the pleura.
And ultrasound waves are entirely reflected by air.
The beam strikes that layer of trapped pleural air and bounces back to the transducer. The machine is blinded to the sliding visceral pleura beneath.
The shimmering marching ants cease. The B-lines disappear. We confirm this pathological state by switching the machine from B mode to M mode, or motion mode.
M mode isolates a single vertical cursor line and plots the echoes along that line over time. In a normal lung, the stationary soft tissues of the chest wall above the pleural line generate straight, parallel horizontal lines.
The dynamically sliding lung tissue below the pleural line generates a grainy, heterogeneous appearance. We call this normal pattern the beach sand lines.
But in the presence of a pneumothorax, all detectable motion below the pleural line is obliterated by the barrier of air.
The entire M-mode tracing becomes a continuous series of straight, parallel horizontal lines. This creates the stratosphere sign or the barcode sign. It is the definitive sonographic hallmark of a pneumothorax.
It is.
But I have to push back here with a real-world scenario. If a patient is intubated, rolled in, completely unresponsive, profoundly sedated, paralyzed with raucuronium, and entirely dependent on a ventilator, how do I trust my pleural sliding evaluation? They aren't breathing spontaneously.
It's a fantastic point. What if the endotracheal tube is malpositioned in the right mainstem? Or there's a massive mucus plug obstructing a bronchus?
Right. The lung isn't moving, so you won't see sliding. You call that a pneumothorax and drop a 28 French chest tube into a healthy hemothorax.
Mistaking apnea or mainstem intubation for a pneumothorax is a catastrophic error. If the lung parenchyma is not being ventilated, you will observe an absence of pleural sliding. To differentiate this from a true pneumothorax, you must identify the pulmonary pulse sign.
The pulmonary pulse is such a brilliant physiological surrogate marker.
It really is. Even without pleural sliding, even in total apnea, the mechanical kinetic energy of the beating heartbeat transfers through the normal solid lung parenchyma out to the pleural line.
So if you observe the pleural line closely, you will see it rhythmically twitching or pulsating in synchronous time with the patient's cardiac cycle.
That transmitted pulse definitively proves that the visceral and parietal pleura are in physical contact. If you see the pulmonary pulse, it's apnea, not a pneumothorax.
Knowing how to adapt eFAST for intubated patients is crucial. But what about adapting it for completely different demographics, like children or patients in the field?
The pediatric population requires a distinct operational approach. The anatomical targets are smaller, the subcutaneous fat layer is thinner, and the stakes regarding ionizing radiation exposure are monumental.
We typically switch to a 5 megahertz transducer. Children have less fat, yielding vastly superior sonographic views compared to adults, and eFAST spares them from CT radiation risk.
But the literature regarding pediatric eFAST is polarized. A 2019 meta-analysis by Netherton evaluated eFAST in children and demonstrated a sensitivity of 71% and a specificity of 95 to 100%.
But we have to juxtapose that with Liang's meta-analysis published in that exact same year. Liang's data revealed a dismal sensitivity of only 35%.
Right? How do we reconcile two meta-analyses published simultaneously with such drastically divergent sensitivities?
It's wild.
The discrepancy is rooted in what the researchers were defining as a true positive. Netherton's meta-analysis evaluated the ability of FAST to detect free fluid. Ultrasound is inherently designed to identify fluid.
Whereas Lang's study evaluated the ability of FAST to diagnose specific intra-abdominal solid organ injuries.
Exactly. It's a crucial clinical distinction. FAST is great at finding a pool of blood, but terrible at telling you if the spleen is merely cracked, but not bleeding heavily.
So expecting FAST to tell you which organ is bleeding is like expecting a basic smoke detector to tell you exactly which piece of furniture in the house is on fire. It just tells you there's smoke.
That is exactly it. A child can sustain a high-grade parenchymal laceration that clots off quickly due to robust physiological compensation. The FAST exam will be completely negative, but the solid organ injury is present.
In kids, non-operative management is the standard of care. We observe them. We don't rush them to the OR unless they are actively exsanguinating. So CT is often still needed if they are stable to accurately grade the injury.
We also have extensions of the protocol tailored specifically for pediatrics, like the FASTER exam.
Dolchowski and his colleagues added extremity evaluation for occult fractures.
They demonstrated greater than 90% specificity for identifying long bone fractures. This assists in immediate, targeted reduction of vascularly compromised limbs in the trauma bay.
Moving beyond the controlled environment of the trauma bay, let's look at the prehospital frontiers.
The miniaturization of piezoelectric technology has been staggering. We have high-resolution, handheld transducers that plug directly into iPads.
But there is a massive debate regarding whether performing eFAST in the field wastes the golden hour of trauma.
The performance data is compelling, though. A study by Brunn demonstrated that pre-hospital staff could execute a comprehensive eFAST in just 3.5 to 3.9 minutes on scene.
And the Melanson study showed paramedics and flight nurses achieving high accuracy. But the true value proposition isn't just knowing the patient has a bleed. It's the implementation of real-time synchronous tele-ultrasound.
Transmitting the live B-mode feed via cellular networks directly to a level 1 trauma center. The attending trauma surgeon interprets the images before the helicopter even lands.
Speaking of smoke detectors giving false alarms or tele-ultrasound giving confusing images, let's look at the ways the FAST exam can lie to you. The pitfalls and false positives.
We've dissected acoustic artifacts, but anatomical mimics can be equally dangerous. Let's tackle false positives for fluid. The literature outlines several physiological structures that routinely fool operators.
Like pararenal fat pads, an anatomically elongated left hepatic lobe, splenic subcapsular hematomas, or mistaking the portal vein or the retrohepatic vena cava for anechoic hemoperitoneum.
The perirenal fat pad is arguably the most common anatomical mimic.
So how do I differentiate pararenal fat from a true bleed?
Well, fat is structural. It's usually isoechoic or slightly hyperechoic with internal echoes. It has a heterogeneous grainy texture.
Whereas fresh arterial blood is strictly anechoic. It is a pure homogeneous black.
Furthermore, blood conforms to the shape of the space, wedging between organs and creating sharp, angular, geometric borders. Perirenal fat presents with rounded, soft, conforming borders.
Operators also have to account for physiological or chronic false positives.
Right, like ovulation fluid in females of childbearing age, ascites in patients with cirrhosis or portal hypertension, or residual fluid in peritoneal dialysis patients.
And what about false negatives?
We already established solid organ injuries without massive parenchymal bleeding, but we must explicitly address complex pelvic fractures.
Because the standard FAST exam is strictly an intraperitoneal evaluation.
Right, it is anatomically blind to the retroperitoneal space. A patient can completely exsanguinate from a shattered bony pelvis into the retroperitoneum, and the abdominal FAST will remain completely negative.
A negative FAST in a patient with an unstable pelvis is clinically meaningless, which fuels the massive debate over training requirements and efficacy.
Consensus varies wildly. Is it 10, 50, or 200 proctored exams? The World Consensus Conference back in 1997 recommended 200.
But Cristancho and Rubiano recommend 50.
And regardless of the exact number, the systemic impact of deploying a well-trained operator is undeniable. The Melniker et al. Study is a paramount example. They demonstrated that integrating routine FAST reduced the time to the operating room from 166 minutes down to 57 minutes.
It also reduced total hospital stay and, critically, decreased the utilization of CT scans from 85% to 53%.
And the technology is evolving rapidly. We're moving toward the integration of intravenous ultrasound contrast agents, which are approaching the sensitivity and specificity of CT scans for solid organ injury.
If we connect this to the bigger picture, an ultrasound is only as good as the clinical context you place it in.
Absolutely. The ultimate utility of the FAST exam is dictated by the hemodynamic status of the patient in front of you.
Let's run a rapid-fire clinical algorithm simulation. I'm going to throw complex scenarios at you.
Let's do it.
Scenario 1, blunt abdominal trauma, hypotensive, FAST is overwhelmingly positive in Morrison's pouch. Next move.
Operating room. Immediate exploratory laparotomy. Do not pass go. Do not go to the CT scanner.
To scenario 2. Exact same patient, but he is hemodynamically stable. FAST is positive.
CT scan to identify the specific anatomical source of the hemorrhage.
Scenario 3. Penetrating thoracoabdominal trauma. The patient is stable. You execute a full eFAST, and it is completely negative.
Serial clinical observation or a definitive CT. A negative FAST in the setting of penetrating trauma is dangerously misleading.
This has been an incredibly dense journey. Let's synthesize the core takeaways for our listeners.
The eFAST is an indispensable triage tool that accelerates time to intervention and minimizes radiation, provided you understand its physical limitations and artifacts.
Sure.
Practice meticulously sweeping the caudal tip of the liver.
Rely on M mode for pneumothorax, but don't forget the pulmonary pulse sign in intubated patients.
And never use a negative FAST to rule out retroperitoneal or hollow viscous injury.
As handheld probes get better and contrast enhance ultrasound rivals CT, we have to ask, how long until AI is integrated directly into these portable probes? Will the machine of the future highlight the stratosphere sign and calculate the Huang score for you before you even have time to process the grayscale on the screen? Keep an eye on the horizon because the FAST exam is getting faster. Keep your edge sharp. We'll see you on the next dip dive.